Öncelikle herkese günaydın. Güne başlarken ben Sayın Dekan'a teşekkür ederek başlamak istiyorum. Mükemmel bir programdı dün. Bugün de bunun devamı olacak. Sabahki oturumda 3 değerli konuşmacımız var. Bu 3 değerli konuşmacı dünün aslında özetini yapacaklar. Kendi deneyimlerini ve bekle gör politikasındaki geldikleri noktayı hasta sayıları ve mevcut tabloyla özetleyecekler. Memorial Sloan Kettering deneyimli Dr. Philip Paty, Hollanda deneyimli Dr. Gerard Beets ve Liv Hastanesi deneyiminde Dr. Oktar Asoğlu verecek. Onun için ilk konuşma için öncelikle Dr. Philip Paty'yi kürsüye davet ediyorum.
Sorry, 10-year experience with watch and wait strategy for rectal cancer. So this is a histogram showing the number of cases treated at Memorial Sloan Kettering by a watch and wait strategy. This began in 2006 with my decision to begin monitoring patients who had convincing complete response. And I was the sole practitioner of watch and wait for about 5 years until my colleagues began to have more confidence in this approach. And slowly over the last 5 years, it's become our standard approach. And we've, under the leadership of our chief, Dr. Julio Garcia Aguilar, we now have a prospective phase 2 trial, which I'll describe at the end of my talk, dedicated to optimizing watch and wait for patients with low rectal cancer who would qualify for neoadjuvant treatment. So we've come to believe that in patients who have complete regression of their tumor, that of all the options available, proceeding to resection, local excision, and observation, that the outcome data are strongly in favor of watch and wait, and it's become our established practice for all but perhaps one in our group who still favors resection. But of the six of the colorectal surgeons in our group, 5 of us are pretty routinely observing patients either on the protocol or frequently off protocol, as we do have many patients come to us having had chemotherapy and radiation and coming for a second opinion, so we don't treat all the patients from the beginning. So this is a typical scenario that would lead to a watch and wait strategy. A patient has a T3 low rectal cancer. We don't have a strict upper limit, but generally most of these patients are within 8 to 10 centimeters from the anal verge. They have a mid to low rectal cancer. And when they're found to have a clinical complete response in their assessment after chemoradiation, they're offered this option. This is, again, off protocol generally, and the acceptance rate is extremely high. I'd say 95% of patients, in my experience, when offered the option of non-surgical management, accept it, even when they're informed that this may have oncologic consequences, some compromise of their local control or cure. They willingly accept this. In most cases, because the standard in the US is to give adjuvant chemotherapy after surgery, this ends up becoming total neoadjuvant therapy, because generally the patients are referred back to their oncologist, they go ahead and get their FOLFOX, and then they come back for observation. So, in fact, people are getting total neoadjuvant as in response to their good tumor response to chemoradiation. However, in the last 5 years, we've pretty much adopted total neoadjuvant therapy as our standard for low T3 rectal cancers. So the majority of patients who are treated at our hospital are now off protocol receiving neoadjuvant FOLFOX. They're assessed by MRI and examination. They go on to receive chemoradiation. And if they achieve a clinical CR, then they're grouped in our watch and wait cohort, which I'll describe to you today. They don't have surgery and they proceed with a surveillance protocol. So before I give our data, I just want to emphasize that I agree completely with Dr. Beets, who feels that watch and wait for rectal cancer is exactly how we manage anal cancer. It's a strategy for local management of the disease, and the goal is to obtain local control without surgery. I think the goal really is local control. Of course, it's cure too, but I think the appropriate endpoint for watch and wait is control of pelvic disease, and with the added goal of preserving the rectum. And the method is to optimize neoadjuvant therapy, which I think is more than just picking the winners. If you're truly committed to this strategy, then you should, in our opinion at least, optimize the treatment to eradicate as many of these tumors as possible without surgery, which is why we've adopted the total neoadjuvant approach. And the second concept is to defer surgery as long as the tumor is actively responding or no longer detectable. So the key is to wait, not to operate, or not to make the decision early to operate, but to wait at least 8 to 12 weeks, and even longer if the tumor continues to regress. So you're seeing if the tumor disappears, and then you continue to watch it closely. So I just thought it'd be worth diagrammatically showing the components of watch and wait, which include, in my opinion, the neoadjuvant treatment, which there are many different strategies. Then the response assessment is very important, which Regina Beets-Tan told us about the role of MRI. Gerard told us about the role of examination, fiber optic endoscopy, digital rectal exam. And this is the second very important component of watch and wait. And the third component is then for patients who achieve a clinical CR to maintain under close surveillance, because local regrowth is, again, part of the expected natural history of this strategy. We're never going to eliminate local regrowths. The intensified regimens increase the clinical CR rate, but the local regrowth rate remains essentially the same. So the natural history, in my opinion, of local management of a clinical CR is very similar no matter how you get there, whether it's by extended radiation, standard chemoradiation, short course, long course, even chemotherapy. Many of the tumors will be cured, but not all, and some will grow back. So I think in order to assess the literature in patients who publish series that say, well, we had terrible results, we had lots of recurrences, rapid, that were difficult, were they really managed by watch and wait? Were all three of these components done purposefully with an optimization of response assessment, adequate waiting, proper surveillance? If these three components are not present, this is not watch and wait. And these components are important for so-called retrospective studies, which again, our study can be considered retrospective, but these components were present from the beginning. I was managing these patients, and they were carefully assessed, carefully selected, and carefully followed. And if you do that, you'll get good results. It's not difficult, but you do have to maintain constant surveillance. So when you read the literature, the entry point for these studies can be really one of three areas. Dr. Haber-Grama's group, actually, when they first published, their entry point was the so-called sustained complete response, which means they were registering patients on their so-called protocol well into this strategy. And we didn't have information on the number of patients who were treated, how many had transient responses, et cetera. And that was one of the reasons their data looked so good in the beginning. They had very small number of local failures, very high cure rate, but they were selecting patients well into this process. The series I'm going to show you begins at the point of clinical CR, the middle point of patient entry when patients are deemed to have a clinical CR and then are therefore put on a surveillance strategy. But of course, the best way to truly assess the effects of the strategy is to register patients prospectively in a defined neoadjuvant strategy, and this is what our prospective trial will do. But actually, there's not much data prospectively in that manner. I think even Gerard's series, which is one of the best in the world, has the entry point at the clinical CR point. He's getting patients referred from all over the Netherlands at the time of clinical CR. So again, this literature is numerator studies to a large extent. We don't have the true denominator. But again, these three components have to be present or it's not watch and wait. And this is the kind of publication that drives me crazy. This was published online in November in JAMA Oncology, which is a very prestigious journal, data from the National Cancer Database in the US, looking retrospectively over, I believe, a 10-year period or so, and showing that patients who did not have an operation had worse survival. And they were saying this means we better watch out about all this non-operative managed watch and wait, that this is a dangerous thing. Well, of course, none of the components of watch and wait are present. You can't impose watch and wait retrospectively. Nothing was optimized. We have no idea how these patients were assessed. Probably most of them didn't have a clinical CR. There's a million reasons why you don't have an operation. You're too sick, you develop metastatic disease, you have a complication. This data means nothing, nothing regarding the efficacy of watch and wait. And this was their conclusion. Our study found inferior survival for patients treated with chemoradiotherapy only. The results are concerning. Studies evaluating outcomes in the real world setting. That to me is complete garbage. They're publishing data, they have no idea how these patients were managed or what their particular circumstances were. So in our series, for the first 5 years, it was clinical complete response was assessed mainly clinically. The imaging was not standardized. We weren't using MRI scanning routinely, which we do now. But again, clinical assessment, as long as it's done very carefully in a serial manner, is absolutely fantastic, and imaging adds very little, in my opinion. These are typical clinical CRs from the first few years when I was doing this. Very conservative. These were convincing clinical CRs. I didn't manage any patients with near CRs. These were tumors that were gone. There were nothing palpable or maybe a little flat scarred, nothing visible except benign looking tissue. Here's more examples of clinical CRs from chemotherapy and radiation. You can see the tumors disappear. There can be some distortion of the rectal wall, a little bit of retraction, even a little bit of inflammation, but no ulceration, no nodularity. What induration is there has to be very smooth and no viable tumor visible. Another example of the changes over time. Again, clinical CRs occur over time, and serial evaluation is very helpful in making management decisions because you're interested in the trajectory of the tumor. Is it still shrinking? Is it getting better? Exactly as we manage anal cancer. Exactly the same. We don't biopsy anal cancer. We don't resect it. We wait until the response is maximized. It's a clinical follow-up for the most part. The one area that I think is a little bit controversial is when you have scar that distorts the wall of the rectum and you have a mild stricture. Technically, in some of the descriptions of clinical CR, a stricture is not a clinical CR. But again, if I can put my finger there, if I can feel that it's smooth, if I can feel there's no nodular, if I can feel it's thin, in this case, MRI is helpful to look at the wall, I would accept this as a clinical CR, even though there's distortion of the wall. But you can see it's a very benign looking distortion. We haven't really been able to go back and look at the various parameters of a clinical CR, but I think the more normal the rectum looks, my bias would be the more normal the exam is, the less likely you'll get clinical local regrowth, but I can't prove that. I think that's probably true. Hopefully we'll learn this in our prospective study. We're going to record all the features prospectively. Here's a clinical CR in evolution. You can see there's a distortion of the wall. There's some inflammation. Nothing there that looks like viable tumor, no nodularity really. I wouldn't biopsy this. This was even after just 7 cycles of Folfox, but this would be a near clinical CR or clinical CR in evolution. Here again, you see this is a nicely regressed tumor, but again, and very helpful is insufflation and desufflation. When you have your scope, collapse the rectum, expand it, look how the wall moves. Is there pliability there? If you can't reach it, you can at least watch the rectum expand. If it's soft, mobile, there's no tumor there. So clinical assessment is not simple. It takes it, you have to pay attention, you have to really look carefully. So again, I'm glad that Gerard has come around. From the beginning, I've always believed this was a test of time. Never embrace local excision. Never embrace trying to force yourself to make a decision. If the tumor is in a state of regression, continue to watch. There's no danger in just waiting. Biopsies, we do use them from time to time, and I think one of the complicating elements in this is very frequently there is residual adenoma. Benign tissues survive radiation better than cancer, and I'm going to focus on this in our next publication. I think probably 15% of our patients develop adenoma at the site of the tumor. And this is poorly described. Are these patients in the watch and wait series or not? They're managed by local excision? Probably, most of them. So that's the one exception where I think biopsies and local excision as diagnostic and therapeutic procedures are important, and they're not that rare. Let's see, how do I move on here? So, and very important, what I've come to believe the most important part of this whole thing, it's not having an MRI that confirms, it's not, you have to make a good assessment, but the really important thing is to continue to follow the patient, because once the tumor starts to grow, then you have to be aggressive with surgery. And I'm happy to say that in our series, every single local regrowth, except one, in a non-compliant patient who didn't return for 1 year, who came in with bleeding and rectal pain, every other patient was detected asymptomatic on routine follow-up. These tumors do not grow back quickly. They can be detected early, they can be successfully operated. I began doing this every 3-month examination, but now over time, seeing the natural history, seeing how it plays out, I've changed to every 4-month examination for the first 2 years. The first 2 years are the critical time. And I think every 4 years or every 4 months is adequate, particularly if it's a convincing examination that the rectum is free of cancer. So you can see this strategy has grown. The blue bars show the number of patients per year. We're now managing over 50 patients a year by watch and wait. About half of them are going on the prospective study, but another half are still accruing to our retrospective series, because again, they're coming in for second opinions. They want to be managed by watch and wait. We can't, and many don't want to be on the protocol. So we're registering as many as we can prospectively, but others are, and so what I'm going to present today is again a comparative series of a 10-year experience of watch and wait, looking at those patients who were managed by watch and wait and comparing them with similar patients who had resection and found to have pathologic CR. And this is more about surgeon preference. My colleagues were not practicing this. So in a way, it's a nice comparative control. It's not like the Renahan series where they took out all the watch and waits and then tried to compare back to the group. All the watch and waits were gone. All the clinical CRs were gone. So there are plenty of patients who had clinical CRs who are in the PCR group. So I think it's kind of a unique series in that way. So here we see the comparison of these groups over a 10-year period. And immediately you can see there's a difference. The watch and wait patients are older by 10 years, by a decade. That's quite a bit older. Very significant difference. They are lower tumors, median 5.5 centimeters. So these are tumors that require AP or coloanal. They're low for the most part. Although you can see the range is wide. Some patients with mid and even upper rectal cancer were managed by watch and wait, but I'm not sure that's always correct. And the other big thing about our series, you can see the neoadjuvant approach at the bottom is quite variable. Some had standard chemoradiation, some had total neoadjuvant therapy. Some even had, 2 had chemotherapy alone. We've included them because they have a clinical CR. And again, there's a difference. The watch and wait group have accumulated more in recent years, so there's more of the watch and wait group who've received total neoadjuvant therapy. More of the PCR patients had standard chemoradiation alone. So our local regrowth rate now, after a 10-year experience, is 22 patients out of 113. That's a That's a crude fraction of 19%. If you look at it on an actuarial basis, it's slightly higher than that. Some of these patients are going to get regrowths, so it's probably in the range of 20 to 25%, the regrowth rate. And again, everyone was managed with surgery, all but one detected electively on follow-up, and most were treated by TME, only 2 were treated by local excision. And you can see the majority of the TMEs are AP resection. This is showing a swimmer's plot, which is a little bit complicated, but it's basically showing all 22 regrowths. And you can see the majority of the little red triangles, and you see the years and months in the bottom. Most of these regrowths occur in the first year to 18 months. And time 0 is at the completion of neoadjuvant therapy. So most of these regrowths occur early. I think most of these are cancers that regressed, that were in the abdominal wall, but they were, in the rectal wall, they were not dormant, they regrew quickly. And the fact is you detect them, you resect them, and local control is fine. There is, though, a long tail on the curve. You can see there are cancers detected at regrowth beyond 2 years, one at 36 months, and one, my patient, 6 years and 3 months. A T2 tumor, the patient was perfectly asymptomatic. I'll never forget looking in there and being shocked to find this thing exactly where his primary tumor was over 6 years later. And in my next talk, I'll tell you why I don't think that's a particular danger, but he was resected and he's fine. These are the list of the cases, and I think the only thing important there is again to say that there were a couple of cases that we didn't get pelvic control. Both patients were non-compliant. One was the one who didn't show up for a year, had a very large tumor, had an AP resection with a positive margin. Another was my patient who refused surgery for almost 6 months while his tumor was growing, and finally he agreed to surgery, became very symptomatic, and he had an R1 resection. And so there is some danger in watch and wait, and it has to do with surveillance and aggressive surgery and patient compliance, and the mindset that sometimes watch and wait doesn't work out. You have to have surgery. And patients sometimes are reluctant when they're going down this road. So here's an example of a very small local recurrence. This is one of the 2 that were treated by local excision. This was so small, so superficial, it was treated by local excision, full thickness excision. This is a more typical regrowth. The pictures above show what it looked like 6 months before, and you look in and there it is. The tumor's growing back into luminally. This patient was an elderly man, had stents put in at the time of his diagnosis of rectal cancer. Conveniently, his tumor took about 9 months to a year to grow back, and then he had his LAR and everything was fine. Here's another type of regrowth that we see. You see an ulcer, inflammation. This is cancer till proven otherwise. These are small things, you can detect them, they're easily resected. This is typical, T2 and 0. We had 3 cases out of 22 that were extraluminal recurrences. They were either nodal recurrence, I think 2 of them. One of them was actually growth from the rectal wall that was growing into the mesentery, so we called it extraluminal. I don't think it was nodal disease, hard to say. But these are rare, and this was a very high-risk patient who had lots of lymph nodes in the mesentery. And you can see on the upper film, the MRI, the lymph node never really went away. It turned black. And our radiologist said, this is a benign scar. Well, it was for 3 years, and it took almost 3 years for this to show itself. This was a difficult resection, but I resected this man 3.5 years ago, and he's still in ED with a nodal recurrence and quite a large lymph node. Why is this worth doing? Because 80% of patients never require surgery. These are the happiest patients in my practice. They have excellent quality of life. We have quality of life data. We haven't put it together to show it, but I can tell you don't need a questionnaire. You talk to the patients. The main symptom these patients have is neuropathy, and I think if I could change one thing, it would be backing off the oxaliplatin doses. That's the main problem. Some have bowel dysfunction, some have erectile problems, men, but very minimal compared to patients who are resected. I can tell you that. The quality of life is outstanding, and these patients, it's like a gift that they avoided surgery, and often avoiding colostomy. So here's the actual surgical procedures in the 2 group. On the watch and wait side, these are all the salvage operations. And you can see, remember, these are the lower cancers, smaller number of patients, but they're low, 5.5 centimeters. And still, the PCR group had a higher rate of AP resection. So you're avoiding colostomy, you're avoiding AP, you're helping patients. This idea that they're going to regrowth and it's going to change it to some terrible operation, that is not true. If you follow patients, you'll be able to do the same operation that you would have done, but you have to follow patients. This is what surgeons don't like. This is a lot of work. You have a big clinic, you got to check people, it takes time, they come in, you have to archive your photos, you got to compare back, has it changed? So it's a little bit of work, but it definitely works. Clinical follow-up works very well. And you can see there's definitely a huge benefit for patients who are on the watch and wait arm. And now one of the things in our series that's a little different, when you look at disease-free survival, the watch and wait patients do worse, but this is because they're older, they're a decade older, and they're dying of other things, heart disease, stroke, other things. So there's more death from other cause, they're older, and you see in the filled in circles, these are all deaths from other cause, making the disease-free survival curve look worse. But if you look at a disease-specific survival, the survival rates are similar. The watch and wait patients are still a little bit worse in terms of survival. Again, I don't view survival as the primary endpoint of watch and wait. I don't think we can control metastatic disease by surgery. And I'll talk more about this in my next talk, but I also think the PCR group is a prognostically more favorable group. We know response predicts outcome. How better than resect the tumor and have the pathologist chop it up? All the patients in the PCR group have had complete response. Not all in the watch and wait group have. So they're inherently, I think, a higher risk group because you're not subjecting them to radical surgery to make a diagnosis. So I think this is going to be true in our series forever, that the watch and wait patients will have a slightly worse survival because they have had, in general, slightly less response as a group. And again, the overall survival was similar. Again, the curves tend to separate slightly, but they join again over time. So overall survival is very similar and quite acceptable and still in a very favorable survival compared to patients who required surgery. These are still very good outcomes. So in summary, we had 113 patients out of 1,000 over a 10-year period managed by watch and wait. Nearly 80% avoided surgery altogether. And there was a 21% local regrowth rate. 95% could be cured. Actually, that should be 20 out of 22. 2 were not, and that was due to noncompliance. 80% rectal preservation and disease-specific survival at 90%, very good. So conclusion, I think the outcomes are slightly inferior because they're an inferior group by nature. There's cancer in some of these rectal walls that have incompletely responded, and I think that puts them in a higher risk group compared to PCR. The risk of harm is small, but it has to do mainly with failure to salvage effectively. I don't think it's about getting the MRI. I don't think it's about what neoadjuvant regimen. I think it's about following patients very closely. It's about local management. And the benefits of watch and wait, I hope I've convinced you, are extremely large. Avoidance of surgery, rectal preservation, quality of life, fewer colostomies. It's not even close. It's enormous, the benefit to these patients. So we believe watch and wait is acceptable and a desirable strategy for low rectal cancers that require neoadjuvant therapy, multimodality therapy. The ones, early cancer, are more controversial. I agree. I think this is more complicated. And finally, I just put a plug in for our prospective trial. We're trying to register people in this trial. I'd say about 50% of our patients are willing to go on the trial, and we're random. It's total neoadjuvant therapy for mid-rectal and low rectal cancers, randomizing patients between chemotherapy followed by long course radiation versus long course radiation followed by chemo, alternating. I doubt there'll be very much difference. There's probably going to be a difference in tolerability and side effects, but I doubt that oncologic outcomes will be any different. The primary endpoint is disease-free survival, but important secondary endpoints are how many times can we preserve the rectum. I can tell you, in this trial so far, more than 50% of patients are going on the watch and wait arm. We're getting enormous induction success. And I just mentioned that our data that I showed you is very similar to other data around the world, which I think is validating the whole thing. And finally, I'll just say, I think there's a biologic reason why watch and wait works. Why can we leave these cancers in there and still be successful? It's because the neoadjuvant therapy kills the high-grade elements of the tumor. What you see is remaining is adenoma, low-grade cancers. These cancers are not very dangerous. They're slow to evolve. They can be resected even after years of follow-up. My bias is the rapid local recurrence are cancerous. The ones that are taking 3, 4, 5, 6 years are adenomas, I believe, microadenomas that are emerging as cancer over time. That's my guess. And this is the sort of evidence you see. This is a radiated patient who's resected, and what do you see? A bunch of adenoma that didn't respond. Adenoma is very radiation resistant, so I think this is one of the keys. Here's an example of a residual adenoma, benign looking tumor, and you see these with some frequency. Thank you.